discuss the intussusception. Intussusception, by definition, it is an invagination of one part of the intestine inside the adjacent one, and this will cause luminal obstruction, and it also cause venous lymphatic obstruction, and with arterial obstruction and ischemic bowel. But let's know what is the types. There is many classification of intussusception. One of the classification is classified according to the site. So classification according to the site will include ilioileal, jejunal, jejunal-ileal, ileocolic, colic intussusception, or even ileocolic intussusception. Other classification according to the direction is proximal inside the other, like ileocolic intussusception, which is the most common, or it is an retrograde, means there is antegrade and retrograde. Antegrade intussusception, proximal inside the distal one, and retrograde intussusception means the distal bowel inside the proximal bowel, like ileojejunal intussusception is very extremely rare. Other way of a classification of intussusception according to the etiology or the cause, and is classified into primary idiopathic intussusception, and it might associated with the hypertrophied lymph nodes of the bowel, which is the most common. Other type of intussusception according to the cause is the secondary intussusception. So the classification of intussusception according to the cause into primary idiopathic due to lymphatic hypertrophy, and the secondary intussusception due to pathological leading points like tumor, lymphoma, polyp, foreign body, and something like that. Regarding our lecture today, it will discuss the primary idiopathic ileocolic intussusception. This slide will show just the causes of secondary intussusception, which is account overall in 10 to 15% of all cases of intussusception in pediatric age group, like Peutz-Jeghers syndrome, polyp, lymphoma, and something like that. But will we talk now, complete our lecture about the primary idiopathic ileocolic intussusception. Again, I will repeat it. Our discussion today about primary idiopathic ileocolic intussusception. We call it a primary idiopathic because the etiology or the cause of a leading point is a hypertrophied lymph node that is occur due to either infection by respiratory syncytial virus or rotaviral infection. Both of them will causing hypertrophied lymph node. So the condition of intussusception might be preceded by a chest infection or preceded by diarrhea. So rotaviral vaccine also might be discriminated as an etiology for intussusception. The baby age is usually from 3 months to 3 years old, and the peak incidence is 6 to 18 months old. Usually it's male, firstborn baby, and complaining from, when the intussusception occurs, the baby will complaining from intermittent, crampy abdominal pain. This intermittent crampy abdominal pain is due to bowel inside the other will cause severe squeezing, colicky pain. This associated again with vomiting that may be bilious emesis in late stages. So, any baby, male especially, even in female, complaining from sudden onset, screaming, crampy abdominal pain, especially if it's preceded by chest infection or gastroenteritis, an age between 3 months to 3 years, you have to put in your mind it's a case of intussusception, and you have ruled it by investigation, by ultrasound, by x-ray, by further examination, because the time factor is very important. Delaying case will cause the failure of non-operative reduction is higher. Let us to go to the surgical reduction. Moreover, the more delayed case will cause gangrenous bowel, perforation, peritonitis, resection bowel, or even the baby might pass into the sepsis, renal shutdown, and even death. So early diagnosis will highly improve the outcome and will highly reduce the morbidity and the mortality. Hours by hours, the condition will worse, passing into more deteriorous condition. Initially, intermittent abdominal pain with vomiting will proceed into the baby to develop lethargy and bleeding per rectum. Bleeding per rectum means ischemic and mucosal slough will occur, and it is a delayed one. So a pitfall to wait a current jelly stool to occur to diagnose the case of intussusception. Regarding examination, the baby with this condition will usually show in early presentation flat, not distended abdomen with empty right iliac fossa, because ileocolic intussusception will causing the mass to be palpable on the right upper abdomen or even upper abdomen. Bleeding per rectum or even PR will show a blood-stained PR. The mass might be palpable by manually by PR if the condition is more delayed. This is a photo on the right side showing a red currant jelly stool. The investigation, there is a diagnostic investigation including a plain abdominal x-ray will show absence cecal gas, again it's called a sign of dance, and with abnormal mass shadow in the upper abdomen with multiple air fluid if the condition is more delayed. Ultrasound, this is the photo of the x-ray. The arrow is showing abnormal bowel mass with absent right iliac fossa gas shadow. The more or golden standard investigation, diagnostic investigation for intussusception is the ultrasound, which either show target sign in a cross section of the mass due to alternating hyperechoic shadow or pseudokidney sign in the longitudinal section of the bowel mass of intussusception. After diagnosis the case of intussusception and doing the diagnostic investigation, the baby should resuscitated, IV fluid, antibiotic. The investigation should be taken, including CBC, renal function. Regarding management of a primary idiopathic intussusception, there will be two parts: non-operative reduction and operative reduction. To decide to take the baby to operative or non-operative reduction, we have to remember the abbreviation 3P. Number 1P is persistent hypotension, means the baby passed into the septic condition. Persistent hypotension not corrected by fluid resuscitation means the baby in septic shock, and this necessitates non-operative surgical reduction. Number 2P is peritonitis. Again, peritonitis means there is a bowel ischemia or bowel perforation, so it's not fit non-operative. The baby needs surgical exploration to explore and resect the gangrenous bowel and to repair the perforation. Number 3P is perforation. Intestinal perforation necessitates exploration, of course. This is about absolute contraindication for non-operative reduction, and these are indication for surgical reduction of intussusception. Other indication for surgical reduction of intussusception is secondary pathologic leading point of intussusception and failure of non-operative reduction. So, in short, a 3 contraindication for non-operative, and there is 5 points an indication for surgical reduction. Non-operative management including is either hydrostatic reduction or pneumatic enema reduction. Hydrostatic enema reduction by injection of the contrast material, Omnipaque, throughout the anus, and it depends on role of the 3 feet fluid for 3 minutes opened into the anus. After 3 trials of that, it's called failure of hydrostatic reduction. But the success is higher in pneumatic enema reduction because the condition is under control. This photo describes hydrostatic reduction, and the photo from the left is showing the close sign diagnostic of the patient with intussusception during injection of contrast material through the anus. Increasing pressure will cause the close sign to move to the left side or to the right side of the abdomen, and gradual reduction in progress. On the photo on the right side showing complete reduction with reflux of the contrast material into the ileum, and the arrow showing the area of edema at the ileocecal valve. Regarding pneumatic enema reduction, we should have a fluoroscope described in the photo and sphygmomanometer to inject or to insufflate air under control, and the therapeutic pressure should not exceed 120 millimeter mercury, otherwise the baby at risk to developing iatrogenic bowel perforation. The Foley catheter transanally taped by the plaster, and under fluoroscope control we insufflate the air controlled by a fluoroscope, showing us the gradual reduction on progressing and reflux of the air to the terminal ileum. This fluoroscope will give an idea about complete or incomplete reduction, give an idea about if there is a pathological leading point following defect developed, or if there is a perforation, iatrogenic perforation, or even if the baby have already perforated bowel by the air being free in peritoneal cavity. If the non-operative reduction it failed, or if there is a secondary pathological point, or there is 1/3P, this is an indication for the surgery. So the surgery, before surgery, the baby should be resuscitated with IV fluid, antibiotic, NG decompression, and the exploration of the abdomen throughout the transverse abdominal incision will show a bowel mass, intussusception explored outside of the abdomen, and reduction by milking, not by pulling. After full reduction of the bowel, we have to ensure there is no secondary pathological leading point, there is no bowel perforation, there is no bowel ischemia. And we have to deal with these three, perforation or gangrenous bowel or leading point, accordingly by tangential resection or bowel resection, end-to-end anastomosis, ileostomy, and so on. Thank you. This is the end of the part 2, lecture 3 in this year with coronavirus. Thank you.